of urinary incontinence (UI) in adults depends on the type of incontinence, its severity, underlying causes, and the individual's overall health and preferences. Below is a general approach. 1. Types of urinary incontinence. Stress incontinence. Leakage during activities that increase abdominal pressure, e.g., coughing, laughing, or exercise. Urge incontinence. Sudden, strong urge to urinate, often associated with overactive bladder. Overflow incontinence. Involuntary leakage due to incomplete bladder emptying. Functional incontinence, caused by physical or cognitive impairments that hinder reaching the toilet in time. Mixed incontinence. Combination of two or more types, commonly stress and urge. 2. General management strategies. Lifestyle modifications. Fluid management. Limit excessive fluid intake and avoid bladder irritants, e.g., caffeine, alcohol, and acidic foods. Bladder training. Encourage scheduled voiding to gradually increase bladder capacity. Pelvic floor muscle exercises. Kegels. Strengthen pelvic muscles to improve control, especially for stress incontinence. Weight loss. Reduce pressure on the bladder in overweight individuals. Smoking cessation. Decreases coughing, which can exacerbate stress incontinence. Behavioral therapies. Prompted voiding. Useful for functional incontinence in individuals with cognitive impairments. Double voiding. Helps in emptying the bladder completely for overflow incontinence. Medications. Anticholinergics, e.g., oxybutynin, tolterodine, for urge incontinence and overactive bladder. Beta-3 agonists, e.g., mirabegron, relax bladder muscles for urge incontinence. Topical estrogen, for postmenopausal women with stress or urge incontinence associated with atrophic vaginitis. Alpha blockers, e.g., tamsulosin, relieve bladder outlet obstruction in men with overflow incontinence due to an enlarged prostate. 5-alpha reductase inhibitors, e.g., finasteride, for long-term management of benign prostatic hyperplasia. Devices, pessaries, support for pelvic organ prolapse causing stress incontinence, urethral inserts or external collection devices, for temporary or situational management. Procedures and surgery, mid-urethral sling, common surgical intervention for stress incontinence. Bulking agents, injected around the urethra to improve closure in stress incontinence. Sacral neuromodulation, modulates nerves controlling bladder activity for urge incontinence or overactive bladder. Bladder augmentation or diversion surgery, for severe cases unresponsive to conservative management. Catheterization, intermittent catheterization, for overflow incontinence or neurogenic bladder. Indwelling catheters, last resort due to risk of infection and other complications. 3. Special considerations. Older adults, balance treatment goals with quality of life, especially for functional incontinence. Postpartum women, focus on pelvic floor rehabilitation. Neurological conditions, e.g., spinal cord injury, multiple sclerosis, tailored management with specialist input. 4. Multidisciplinary approach. Involves primary care providers, urologists, gynecologists, physical therapists, and continence nurses as needed.